Hello, thanks for tuning in to the NASGP's October 2022 educational webinar. This month is on the presentation and diagnosis of brain tumours and it's brought to you by Lorcan Butler. Sadly, Lorcan's camera didn't work, so we've got the slides and audio, but just you can't see Lorcan on the slides. This is coming to you as a YouTube video, but also as a podcast. The slides aren't too heavy in graphic images, so you should be able to catch the greater gist of everything with actually not having to see the slides anyway. So I hope you enjoy, and I'll leave you now for Lorcan Butler to introduce himself. Thanks for watching and thanks for listening.
Good. So first of all, just introduce myself. So my name is Lorcan Butler. I'm an optometrist with the Brain Tumour Charity, and my job is to go around and engage with healthcare practitioners, primarily opticians, but I'm doing GPs, ANPs, and anybody involved in a patient's journey. So I've given this talk to the Neuro Convention a couple of months ago, also to Health Education England. There was 300 AHPs coming on to webinar, and I've also just done the Royal College of Physicians Belfast conference. So this is just to talk to you about kind of some of the signs and symptoms of brain tumours. It can be very difficult, one for GPs, and it's just trying to kind of give you some clinical pearls, something you can take back to practice if you're in practice today, something that hopefully you haven't come across before. And I'm quite happy to take questions at the end. So headaches can be a very complex and difficult one, non-specific symptom, along with many others. But sometimes people do automatically think that they do have a headache. It's one of the kind of worst they've ever had, and it could be a brain tumor. And you probably get quite a lot of people do have querying of a brain tumor with headaches, especially if they have maybe a family history. My talk today is just going to talk about some of the clinical signs and symptoms apart from headaches, and then we're going to talk about different kind of levels of risk. So we're talking about red flag, orange flag and yellow flag, and then just talk a little bit about kind of the investigations and some signs and symptoms towards the end. So the chance of picking up a brain tumour in primary care practice is very slim. You might get one in your whole career. You may be unlucky to have one or two in 1 week, so it can be very difficult to choose. But the annual incidence of brain tumours is quite small. However, people with brain tumours do tend to present with kind of quite vague and, as I said, non-specific symptoms, and it's just trying to give you some idea. To give you some background about brain tumours, approximately 12,000 people a year are diagnosed, and that's just including children too as well. So it's the biggest cancer killer for under 40s. And I'm sure we're all probably parents or, aunties and uncles, and that's over one child a day is diagnosed with a brain tumour. And we'll go on to the age profile in the next slide, but just to kind of chat about kind of why are they increasing, and it's maybe an aging population. There's a couple of hypotheses. One of them is that we're living longer. Obviously, the cell DNA is damaging too as well. Obviously, better screening. I'm not sure where our delegates are attending today from Scotland, Wales, England, but you might be in a specific area that does have a distinct referral pathway, which may be slightly better than others. But we're very aware of brain tumours in social media. So Joe Biden, the American president, he had a son who died of a brain tumour, very aggressive brain tumour, 5 or 6 months from diagnosis to death. Taylor Swift's mum is living with a brain tumour, and we had one of our supporters, Tom Parker, who is a pop singer with quite a well-known band called The Wanted, and he unfortunately died of a very aggressive brain tumour. He had a GBM, a glioblastoma multiforme, which is a high-grade, grade 4 brain tumour. So people are aware of these and seeing these on social media, and they may have concerns. So just talking about the age profile, so just bring your attention down towards the end, the bottom of the graph. So just on the left-hand side, third from the bottom, we've got 60 to 69, 70 to 79, and 80. And this tends to kind of be the main kind of larger population we're talking about, and it tends to kind of be females more so than males, maybe before kind of 55 and 60. So females have a more propensity for looking after their general health and are a bit quicker off the mark and consulting their GP with any concerns, while males tend to be a little bit later in years they come in. So especially kind of people coming in with new presentation of headaches or new presentation of changes noted by themselves or possibly a loved one, but just to give you an idea of the age range. So as the age increases, the incidence of the brain tumour increases too as well. So headaches does tend to be a difficult one for primary care. So you do tend to get kind of, quite a lot of presentations, but only about 2% are referred to secondary care for further assessment. But it can be quite worrying, as I said, especially if somebody has other symptoms too as well. So as I said, these can be focal neurological deficits. They can be a change in their consciousness, their memory, their speech, their gait, their balance. So a lot of kind of vague symptoms, which are very, very difficult to pinpoint. And this is trying to kind of guide you and kind of give you some clues as to maybe if the next person who comes in and you are suspicious, what to look for. So headaches by themselves as a presenting feature for brain tumor are very, very small. And some of the papers range anything from 2 to 16%. So if you look at a lot of the clinical papers, headaches is a very high presenting feature, but not necessarily by itself. So a lot of people, approximately 60 to 70% of people with brain tumors will actually have headaches sometime along their journey. But in terms of the only isolated presentation is actually quite small. So bear that in mind. This was a paper that was done by a girl called Fiona Walker. She's a neurologist. She was talking about people's changes more than symptoms. So when we go to college, we're taught about signs and symptoms, what to look out for. But when the patient comes through the door, they may not necessarily mention symptoms. They may say they've changes, or especially if you have a chaperone policy and a loved one comes in, a partner, parent, friend, spouse, they can come in and they can say things such as just wasn't quite right, wasn't been himself. There's been a change in the mood, maybe more depressed, or it can be the opposite, there's a loss of disinhibition. And so it can be kind of case of personality changes and then cognitive changes, which are masked then by Alzheimer's, dementia, Parkinson's, etc. So brain tumors can be easily missed because they have, as I said, no specific symptom. So they tend to have a raft of symptoms. Also seeing a person coming back into the practice too as well, maybe on a more frequent basis. If you look at the patient record card in the system and you find that they haven't been coming back, and then there's kind of 3, 4, 5 visits over the last kind of 5, 6 months, that should kind of raise your risk of suspicion too as well. Obviously with COVID it can be quite difficult, but we do tend to kind of in Britain tend to have kind of a stiff upper lip, and I don't want to bother you and I didn't want to cause any fuss, and we just tend to get on with it. But sometimes when people are making more frequent appointments, that can kind of lead a clue to as well. Some of the commonest changes reported by the patients and also by the loved ones, they tend to be quite explanatory up towards the top: extreme tiredness. And then the words down towards the bottom tend to be words that patients with brain tumors have actually described when they did actually have a brain tumor. They presented to a GP. And some of these, obviously, you hear quite a lot, but cognitive issues, not on the ball, not being able to speak, not being able to write, having difficulty concentrating, etc., and difficulty multitasking. Unfortunately, here in the UK, we tend to have a high rate of people presenting to accident and emergency. So there's only 2/3 of people will actually go straight to accident and emergency. And that's quite difficult because when they do turn up at accident and emergency, it tends to be a late diagnosis, and it tends to be a more kind of, poor prognosis, but it tends to kind of be a late stage. So people may have the symptoms, but they're afraid of going to the GP, or they can't get an appointment to the GP, and then they persevere and persist, and then they just go to accident and emergency. And it does tend to be quite poor. One of the other statistics we have, since it's not on the slide, but approximately 50% of people who go to a GP sometimes get misdiagnosed too as well. So what tends to happen is, especially for brain tumors, we hear things such as depression, posture, stress, anxiety, and it takes maybe kind of 2, 3, 4, 5 visits. So that quite another reason why, and difficulty getting appointments, as I said, with COVID, but that statistic is going back pre-COVID. So this is one of the ones that we had going back to a survey that we asked our community, which was going back a couple of years ago, and asking them how many times did they see the GP. And over 1/3 of people did actually go back to their GP more than 3 times, so possibly 3, 4, 5 times. And again, it can be very, very difficult, and that's what we're here to help you as much as possible, because there are no specific symptoms. It is very, very vague, but people tend to kind of have the revolving door of coming back in again and coming back in again with kind of unresolved issues. And there's lots of signs and symptoms we associate with brain tumors, and there's over 130 different types of brain tumors, and some of them will present with different symptoms and different signs depending on the location of the brain tumor. So 2 different brain tumors could be totally different, and some of the symptoms and signs people complain of can be headache. Also can be seizure too as well. So sometimes people having seizures, and then vomiting, cognitive changes, I said, are difficult to identify because they can be associated with that kind of age range of people with dementia, Alzheimer's, etc. cancer, Parkinson's. And then where I tend to come in is vision problems too, as well as an optometrist. Obviously, somebody comes in with a history of previous cancer. Again, we need to prick up our ears, and we come into a situation where we're getting approximately 20 to 40% of people who've got cancer elsewhere do tend to have metastasis in the brain. And the two common ones tend to kind of be lung and breast. So especially if somebody does have a previous history of cancer and they do present with new headaches, you do want to kind of, be listening to these and be cognizant of the fact that it could be a secondary tumor, and especially kind of new patients coming in. And maybe they're saying that there's a change in their headache type. Maybe they could be an habitual headache sufferer, but the frequency and severity of the headaches is changing. And again, it could be something that they're aware of and wanted to bring to your attention. People kind of ask me, is there any specific type of headache, or is there any specific kind of, primary? Is it associated with one particular thing? And the answer is no. So with brain tumors and headaches, there's no specific feature or pattern. There's one study done by a neurologist, David Kernick, which was done a couple of years ago, and he was saying that it's more similar to a tension headache and not related to migraine, where you get the phonophobia, the photophobia, and want to kind of lie down in a dark, quiet room. And I've got a slide coming up towards the end, which talks with the neurologist about the specific type of kind of headaches. But they tend to be progressive in nature. They don't tend to be acute. And again, they tend to be enough to cause the patient to have a concern and to come seeking your assistance and expertise. So we're going to talk a little bit about kind of the red flags. So these have a PPV of 1% and over. Again, they tend to kind of be ones you want to be kind of acting on quite quickly. So papilledema is one that I've given quite a talks to different kind of healthcare practitioners before, primarily opticians. The reason being papilledema is quite high in the radar for opticians. We had a locum optician unfortunately missed a case of papilledema in a young child who presented with headaches, and the child had hydrocephalus and unfortunately passed away. But she was sued for manslaughter and clinical negligence, and it was the first person ever in UK optometry to have this situation. So we as a profession are very, very acutely aware of papilledema and its presentation. And again, with doctors, I think doctors would probably admit they do find it difficult maybe to have a look inside the back of the eye. They may be not confident in detecting it. I gave a presentation with a neuro-ophthalmologist from Birmingham, Susan Mullen, and Susan's very big into IIH. And we talked about the prevalence of ICP type headaches. And with IIH, it tends to be young females, childbearing age, and just 90% of them will be symptomatic. 90% of them will be obese too as well. So you'll tend to find they will be symptomatic. Vision problems, these are again kind of one or two clinical pearls you may not be aware of. So sometimes people present with vomiting, seizures, vision problems, a change in vision. So they used to be able to see things, but now they aren't. And you might hear that quite often. But again, don't be afraid to refer them to your local high street optician or domiciliary opticians. If somebody's at home, they aren't able to get into the high street. Double vision would be a medical emergency, and double vision can sometimes masquerade as a stroke or a little TIA too as well. But again, a double vision should be straight away at referral to the ED. Something you may or may not have heard of called a TVO, which stands for transient visual obscuration. And this tends to be a very common finding with a papilledema and with ICP-based headaches, where the vision just tends to disappear momentarily in one eye for 2 or 3 seconds. And unfortunately, it doesn't tend to be a symptom which is voluntarily given by a patient when they talk about headaches. So you may have to probe for it. And the other next line I'm going to talk about is headaches, a pulsatile tinnitus. And again, this is a very common finding with people with ICP-based headaches, is they have a ringing in the ear, which unfortunately is mistaken for an ear infection. So what tends to happen is they're given treatment for an ear infection. So some of the questions you could ask are very, very simple closed questions, such as for the change in the vision is, have you ever had a momentary loss of vision? And that would exclude the presence of a transient visual obscuration. The pulsatile tinnitus then tends to be a whoosh, 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 similar to holding a seashell up to your ear or when you're walking along the beach and the waves come up to you. And again, asking a very direct closed question, do you have a ringing noise in your ear like a seashell? So if people come in with ICP-based headaches, those are two very, very clear, quick questions, but you do have to be quite distinct with the questioning. If you ask somebody about blurry vision, I think the majority of people would say yes, but being very closed questions, yes, no. The consciousness, the memory, the confusion, and this coordination, again, it can be difficult for both the patient to be aware of. Sometimes they aren't aware of it, and it'll be a family member or friend who'll mention it. And then headaches causing awakening from sleeping. And again, this would tend to be down to the ICP. So what tends to happen is the CSF can drain in the supine position. You get a secondary buildup of ICP. Then that tends to lead to a very severe headache, that people will wake up with a headache. And then when they get up and move around and the CSF can drain, the ICP decreases, and then the headache ameliorates. So people tend to say, yeah, it's really, really bad when I wake up in the morning time, but after I get up and get dressed and go to the bathroom, it's not too bad. And then we talk about the absence seizures, again, which are very, very difficult. It's not the tonic-clonic type seizure we tend to get with epilepsy, but it just tends to be kind of a momentary kind of, lost in motion. They just tend to get into a gaze where they just don't tend to kind of make conversation too as well. And person will admit to you that they're just kind of, that they can't remember, they weren't aware. So their eyes will kind of not blink and they'll just kind of stare off for 5-10 seconds. And again, this can be difficult for the patient to be aware of, but a family member may be aware of it. And obviously we touched upon the previous cancer and the risk of a secondary cancer. So those are the red flags. And then if we look at the orange flags, again, something to kind of, keep in your mind, mindful of the possibility of a brain tumor. And these tend to be where a diagnostic pattern hasn't emerged. So you might have given them a headache diary, you might have asked them to come back, you're doing some safety netting and asked them to return, and they still find it's persistent, it's getting worse, it's not easing, analgesics, NSAIDs aren't taking any kind of edge away from it, and they're concerned. And then we talk about the Valsalva-like maneuvers, and this again tends to kind of be quite easy to explain. When people cough or they sneeze or they shout or sing, the ICP increases and the headache tends to intensify. So what will people say to you is they may say things such as, I'm afraid to sneeze just in case it makes it worse, or I'm afraid to cough just in case it brings the headache on, or when I'm bending down to tie my shoelace, it gets worse. And again, we talk about projectile vomiting, sometimes in conjunction with nausea and sometimes without nausea. And again, this would be your very typical kind of ICP-based headache. And then we talk about the headache, again, being progressive in nature and increasing in severity and frequency, not your usual headache. And especially in those kind of older people over kind of 50 years of age, when they present to you and they've had no history whatsoever of a headache. And again, that should kind of prick up our ears too as well. And we already spoke about kind of the headaches being so severe that they are waking people from the sleep. And sometimes people might say to you, I'm afraid of lying down and falling asleep on my back. I prefer to kind of prop some pillows up my back and kind of fall asleep in kind of a semi-upright condition too as well, because they know when they wake up in the morning time, the headaches can be so severe. And then if we talk about the yellow flags, again, so decreasing in risk, but they do require appropriate management and again, good safety netting. Okay, so when people come back to you and they still have concerns about the headaches and you're thinking, is that a migraine? Is it a tension type headache? And then we're talking about the focal neurological loss, weakness that can lead to little trips and falls. And then we talk about the cognitive disorders too as well, the memory loss and the personality changes, people becoming very, very aggressive, a loss of inhibition, or the personality changes noted by a loved one. So again, I'm not too sure where our delegates are joining us from today, but there could be specific pathways for headaches and specific areas might have a specific kind of, guidelines, but I've mentioned a few here. So we got the Scottish Intercollegiate Guidelines, we have the BASH, and we also have the nice one too as well, the NG12. And again, you might have a rapid access center you can refer people to, but just been aware of the kind of the types of headaches we mentioned. So you'll tend to find, as I said, some of the clinical papers do talk about headaches being associated with a brain tumor. And in one paper, it was high as 56%. I'm going to show another slide in a moment, which ours is slightly higher, 59%. Another paper talks about 70%. So these people who've experienced headaches as part of the signs and symptoms, but not necessarily as an isolated incident. So this is one of our findings from a survey we did with our community, asking them to list down the symptoms that they had prior to their diagnosis. And you can see from the top, headaches comes in at 59% in comparison to the previous slide, which is 56%. So I think it does correlate quite well. And you can see then fatigue, seizures, balance problems, vomiting, and memory and vision tend to kind of be the top 5 or 6. So definitely headaches are there, but not by themselves. Okay, so as a lone, isolated presentation, they do tend to be quite small. But that tends to be a good snapshot too, as well, of kind of what people mention 2 or 3 of those symptoms. So headaches in conjunction with balance problems, headaches in conjunction with seizures, and this is something we refer to as headache plus, and I'll just describe this later in 1 or 2 slides. So this was a paper that the Brain Tumour Charity helped fund by a neurologist, Dr. Fiona Walter, and she talked about the opportunities that GPs can have when they miss diagnoses in people with brain tumours. And she was speaking to patients and their carers, their partners, their loved ones. Now, I know this is quite a busy slide, but just to give you an idea of kind of, some of the things that patients say. If we look at the large center one too as well, and then the kind of spokes from that kind of hub, they tend to kind of be the difficult ones. So again, there's lots of there. It does tend to be complex. There's no one specific symptom, but again, brain not working probably, change in person, out of character, they weren't themselves, etc. Those are things to watch out for. And again, people do tend to kind of, be afraid to complain. They don't know how to do it properly, and they don't make a fuss. They don't kind of, annoy you. You're a busy professional, and they sometimes find it difficult to put it into a symptom. And this is where we, as medically trained clinicians, find it difficult to kind of, elicit sometimes the main presenting feature, the main problem that the person is having, and that can be difficult too as well. And we try to assign, one particular possibility in a differential diagnosis that it could be this, and then prescribe or advise, guiding accordingly with a safety net and ask them to come back. So these are some of the words that they've actually said. So these are some of the recommendations that came from that paper back in 2019 from Dr. Fiona Walter. So it's asking about kind of what we can do as locum GPs and sessional GPs and other kind of healthcare practitioners too as well. So the Royal College of General Practitioners is aware that a 10-minute appointment isn't sufficient to address patients' needs, and it should be longer. So we're probably all very aware of that, and it puts you under time constraints, under pressure too as well. And that the symptoms the patient comes in with are very, very vague and it's complex. But don't be afraid to kind of, ask patients to bring a list of symptoms in. After COVID, I said with a chaperone policy, you may want to bring somebody in who maybe has a partner, family member, a loved one who can come in with them too as well. And obviously going into maybe a practice you haven't been to before, looking at the patient records, if you do have time prior to the appointment, or maybe getting a bit early and seeing kind of what the history is, and then trying to kind of say, is this a person who is kind of frequently coming in, or is this a person who has never been in the practice before, or maybe 5 or 10 years ago, and is now showing repeated kind of visits over a short period. And then encourage the follow-up appointments there and then. Again, people don't want to disturb you. You're busy people, and they'll just go once and then they'll go home and they'll suffer. And rather than going back a second time and embarrassing for them and embarrassing for you, and the symptom hasn't disappeared, they will just suffer in silence, and maybe they'll just attend A&E when it gets too late. So don't be afraid to make that appointment in your diary, and maybe if you aren't able to attend themselves, but maybe to the next GP that's coming through, and kind of put down a brief history that they can understand where it's coming from on the patient record. And then obviously you're going to have that caveat that outside of GP's working hours, or if the practice is closed, or if nobody's able to answer the phone, or if it's busy, that there is the local accident and emergency, the ED, to present to. And that's very important medical legally too as well, to be informing them and document that on your patient record communication, and write that down, that patient was advised to return to practice, and outside of practice hours then to present to accident emergency. And again, trying to look at the patient record time, if you do have time. I know it can be difficult, but try to identify patients who just don't fit the kind of the normal kind of, pattern. They're coming in on a sporadic nature, and they don't tend to kind of, have one symptom, it's kind of varied symptoms, and previous presentations haven't been kind of, fixed. And then also, when we're going to send somebody to imaging, it's also quite important to tell them why we're going to send them to imaging. So it is a differential diagnosis. So it could be lots of things, but I'm sure you want to get this sorted out. And kind of people prefer that, rather than be kind of left in the dark and attending the hospital unsure of why they're going. Obviously, there is a slightly higher risk of incidental findings at 10%, being found on kind of routine screening, and that can kind of be cause for concern too as well. So that might be sometimes a reason why people are a bit reluctant to kind of refer on for neuroimaging. So I'm not too sure if anybody's heard of Gateway C. So Gateway C is a fantastic resource organised by the NHS Christie in Manchester. It was piloted a couple of years ago just for GPs, and it's an educational tool which talks about the main 16 different types of cancer that a GP, locum GP, will come across, and talks about signs and symptoms, referral pathways, and also goes through some very, very simple recorded videos and kind of case studies. And brain tumours are there. We're probably in the top 3, top 4 of those 16 videos. We got involved with the Gateway C, trying to help them in any way, talk about kind of signs and symptoms. So it's free of charge. So it used to be just specifically for GPs, but now it's very helpful for ANPs and other healthcare practitioners to go in and try to upskill next time a patient doesn't turn up. If you do have kind of 5 or 10 minutes, that's free of charge, and wonderful resource for your CPD, and it's got live webinars too as well. It is accredited with the RCGP, and they do tend to have very, very simple access. And you just go online and kind of find out when the next webinar that takes your interest. The webinars, the recorded webinars, are a bit longer. They can sometimes maybe take 45 minutes, an hour. You might not be able to do one in a full day, but it might take 2 or 3 sittings. But just in case you do want to get some further information about particular types of cancer and statistics and routes of referral, signs and symptoms, etc., it's a wonderful resource. We were involved in helping them produce the brain tumour one. And this is the gentleman I was chatting about, a neurologist from Salford, Dr. Moorjan. And he was talking about the kind of the hint that it's usually kind of, in conjunction with something else. So we talk about a headache plus. So headache in conjunction with neurological focal loss, headache with cognitive change, headache with visual change, etc. So rather than kind of, a migraine, and so it's more kind of progressive in nature, not acute, and enough to cause concern and maybe repeated visits to the GP. This is something that you may or may not come across. This is a Brain Tumour Charity campaign that we had, just in case you're wondering who we are. We did a campaign with the RCGP a couple of years ago, talking about the early diagnosis of children, and we're able to get the diagnosis rate the referral rate from 13 weeks down to 6.5 weeks. And this is a small concertina card that you may have seen in practice, you may have seen in hospital, and it's basically talking about the signs and symptoms that different children will present with, and it just tends to be specific age categories. And the idea here is that if a concerned parent or a concerned healthcare practitioner had 1 or 2 issues that the child was complaining of, that they could refer them to the local GP and ask for the GP to refer them for ultrasound or neuroimaging or for further assessment. And it tends to be quite an old one. We have updated it. And this is our most recent one that you may see, depending whereabouts in the UK you are. It's launched a couple of months ago, and it's called Better Safe Than Tumour. So the digital assets you see on screen tend to be images that are displayed on the back of buses and in toilets across the UK. And it just talks about kind of, it's a multi kind of, age condition. It doesn't represent any demographic. It can kind of hit anyone at any time. There's photographs of young children, there's photographs of middle-aged people, older people of various backgrounds. Little kind of bubbles you see inside the head are different symptoms they can have, such as balance issues, vision issues. And the idea here is if people see this, they can go along to you and they can say, I've got 1 or 2 concerns. They can go on to our website and we can print off their concerns, and they come into you. They can download it onto their smartphone and they say, I was on the Brain Tumour Charity's website and I have 1 or 2 of these symptoms. I have concerns to come in to see you. So just in case people come into you with this on their smartphone, you know where they're coming from. You may or may not have seen this either too as well. So it's only been out a couple of months, but better safe than tumour. So thank you very much for listening to me. I know it's a busy lunchtime, so what I'm going to do is open the floor to questions. I'll pass back to Ellie and Richard. If you want me to go back and show any slides, please feel free. I'm quite happy to have a go at answering any questions if there are any.
Thank you, Lorcan. That talk was so helpful, really well targeted to GPs, and like lots of really nice practical steps as well for people to take, particularly like the workshopping of about seeing patients. It would be great to know if anybody who is watching has got any questions about anything that came up about cancer keys, about the workshop points, about signs and symptoms. You can shout out or pop it in the chat, both fine. Dr. Rana, do you want to kick off?
Yeah, hi. I just have a question about the imaging. Is like MRI better than CT? Like, how do you choose as a GP? So we have access on the Isle of Wight for a direct CT scan for the head, not, I don't think, for the MRI as such. But if you could just give a little bit more pointers towards that, would be helpful. Thank you.
Yeah, that might be outside my sphere of expertise, Dr. Rana. Maybe Richard or Ellie may want to jump in answering that question. It's going to be down to you with regard to which area you're in. You may have a kind of a rapid diagnostic centre. You may be able to request a CT scan more than an MRI scan. It all depends where your emergency department is too as well. But sorry, in terms of my qualifications, I wouldn't be able to guide you in what's the best one. Maybe Richard or Ellie could jump in on that one.
Yeah, I'm afraid not, Amanka. I don't know the answer either. It's something. If you're in that situation where you're considering a CT scan, my first thing would be to just pick up the phone and speak to the radiology team, or see if there's some guidelines on your local CCG website. But otherwise, I don't know. In my experience, when I have submitted a request for a scan like this, putting as much clinical information on it as possible, and even a note to the radiologist saying, even asking that question, I have open access to CT scan. If you think this is for MRI, obviously please escalate. Would be my advice there. And of course, we've got 20 GPs on this call, so if anybody else has got an answer there for Amanka, then please do chip in.
That's lovely. Thanks, Dr. Fieldhouse. Oh, did somebody want to contribute? I was just going to ask Dr. Lorcan, I don't suppose off the top of your head, you know any good clinical resources beyond Cancer Keys that might answer that question?
Apart from NICE, we're guided very much by kind of NICE guidelines. All the evidence that we kind of do is evidence reviewed, kind of peer reviewed, and we just tend to kind of stick with NICE. We did some training with some AHPs a couple of months ago. They were using, especially for children, they were using the CCLG guidelines. So the Children's Cancer and Leukemia Group. So they were using the CCLG as part of their kind of, clinical management guidelines. So I think depending on who you speak to, medico-legally, they're going to go by the professional bodies guidelines, then followed by maybe kind of, national guidelines.
Thanks. Dr. Rana, have you got any follow-up questions?
No, I'm all right. Thank you. I think, yes, I've seen this once happening when requested a CT, they change it to MRI. The radiologists change it to MRI themselves. So that has helped. Can I just add one more thing? I was, while listening to Lorcan, I looked into System 1, and all those symptoms that you expressed as a red flag, orange flag, is also part of the Ardence template on the headache. So if you click on the headaches, and then it shows all those symptoms, and it gives you possible differential. I'd never noted that before, so I've seen it first time. So thank you for pointing, kind of pointing our attention to those kind of symptoms.
Sorry, Ellie, Richard, I've just got one thing I forgot to mention, sorry, is that we still are on the RCGB website as the clinical toolkit, that HeadSmart one. If I just bring back the slides, maybe I can't. Sorry, it just disappeared.
That's okay, if you can find it, let us know.
Yeah. But what I meant to say was we're still on the RCGP website as the clinical toolkit for children with suspicion of brain tumours. So if a child does come in and you're suspicious, don't be afraid to use the RCGP website.
Rob, thank you. Anna, Dr. Finkelstein, you've got a question as well.
I was just going to respond to the query about when we use CT or MRI. Years and years ago, I was a paediatric trainee before I went into GP, and I did a paediatric neurology and neurosurgery job. So I looked after quite a lot of kids and adolescents with tumours. And I think it's still the case. It certainly feels it from my GP experience that if we're worried about stuff acutely, like acute raised intracranial pressure, bleeds around tumours, that sort of thing, then kids would go for a CT. But in terms of actually diagnosing stuff, in my experience, I think CT can miss stuff, particularly stuff in the posterior fossa areas. So I think, as I understand it, even these days, it's years ago since I did that job, that, if you're worried about acute stuff, CT is useful in ruling things in or out. But if it's more kind of subacute chronic, like a headache presentation with maybe some neurological signs, then actually MRI is going to give you the best answer.
That's lovely. Thank you so much.
Yes, thanks, Anna.